My name is Dr. Vera Tarman, and I'm an addictions physician working out of Toronto, Canada. Today, I want to talk about medications and surgery for obesity. Basically, there is no silver bullet. The purpose of this talk is to look at the various options that are given to people when they go to see their physician dealing with obesity or perhaps metabolic syndrome, diabetes, high blood pressure, high cholesterol. They're almost always asked to lose the weight. And often what happens is the person will say, I lost the weight, but I keep gaining the weight back. Eventually the physician will say, all right, we have to find another intervention because the weight can exacerbate many conditions. So there are many interventions to address obesity. Let's start with talking about the body mass index. This is a measure of obesity that's used quite commonly. It's recognized as not being a great measurement, but it's used all the time because it's a universal term. We see it in clinical work, we see it in surgery, we see it in research, so that researchers can talk to researchers across the world and know that they're talking about the same thing. It's a term that's used amongst clinicians so that you get a sense of what level of obesity we are talking about. For example, bariatric surgery is proposed when a person reaches a body mass index of 30 or 25 with metabolic complications. Insurance will fund something, the body mass index that is 30 or higher. So what is the body mass index? It's an actual ratio of height and weight. So on the internet, there's a tool that you can plug in your height and your weight and you get your number. The goal is to be between 20 and 25. That's considered healthy weight. And that's the green in this diagram behind me. And the far end of the spectrum where I'm pointing blue, that's considered underweight. Overweight is between 25 and 29, that's the yellow, and orange is obese and red is morbidly obese. Problems with the body mass index are, of course, that when you weigh somebody, what are you actually weighing? What if the person have more musculature? Men are often classified as morbidly obese when they're actually quite muscular. People know it's not a great measure, but it's used because everybody else is using it. A much better measure is called a waist circumference, and that's basically the measure around your waist. When a person pulls out a tape measure, you know that they understand the type of obesity that is of concern. And just a word about fat. We use that word loosely. Let us acknowledge our fat or our adipose tissue as an endocrine gland. It actually serves us well. It has many useful functions. So much of the processed foods that we eat today damage our adipose, our endocrine system. By having a better food plan, which does not involve processed foods, we respect and treat our adipose tissue so that it can serve us well. This is not about fat shaming. It's about reclaiming our fat and making it work for us. Getting back to the idea of the body mass index, if we know that it's not that good, why are we using it so much? As I said, it's a universal measure. It often anticipates medical consequences. We've realized that when a person has a body mass index of over 25, especially over 30, the chances of getting diabetes, of getting high blood pressure, of getting high cholesterol, of getting immune compromised conditions, of worsening arthritis, of possibly or even initiating dementia like Alzheimer's, feeding cancer, all of these are now classified under metabolic syndrome and are related to the body mass index. What happens when a person tries to lose weight? They usually do, but then they gain it back again. This has happened so often with physicians. They don't want to make the suggestion of losing weight because they know that the person will likely regain the weight and more. In fact, patients say, I dieted myself into my 300 or 400 pounds because every time I lost the weight, I gained back more. Physicians don't want to suggest that the person lose weight unless they can actually offer an intervention that can support this. Let's treat the conditions that you've developed already and just don't gain any more weight. That was the state of bariatric medicine for quite some time. For those people who became morbidly obese, a body mass index of 35 or 40, they could qualify for bariatric surgery even at 30 or 25 if they had medical conditions like high blood pressure. But for the most part, surgery would not be urged until a person was considered morbidly obese. This is the pyramid of medical interventions, doesn't matter what body mass index, the concept of diet, of lifestyle modifications has always been promoted. Since physicians didn't acknowledge the addiction dynamic, would just go, oh, there it is. The patient has regained their weight again. Let's not even bother. Really, you could make that pyramid start here at this level here, pharmacotherapy and surgery. That's where medicine has stepped in. And the pharmacotherapy wasn't that successful until the last few years. Primarily, the medical focus has been on bariatric surgery as a condition of bariatric medicine, which is basically the treatment of obesity and obesity-related conditions. Started off as a bariatric surgery because lifestyle modification didn't work, meds didn't work that well. When you really needed fast action, you went to the surgery. Bariatric surgeons dominated the scene maybe 15 years ago. A number of physicians did not want to do surgery, starting off with pharmacotherapy, but the gold standard of obesity practice was surgery. We have actually five different types of bariatric surgery, and I'll just go through them very quickly. We have the adjustable gastric band, we have the Roux-en-Y gastric bypass, the vertical sleeve gastrectomy, and what's called the biliopancreatic diversion with duodenal switch. Adjustable gastric band, it's basically just a band that can be moved at various points on the stomach pouch, and that can be readjusted at various times. Basically, it restricts the amount of food that can go into the stomach. That's all it does. It's a restrictive device. It's probably considered the least invasive and often the first choice. The Roux-en-Y is maybe the most well-known one. And this is where you bypass the stomach and go directly above the stomach, the esophagus area, right to the duodenum. The duodenum is the highest real estate of where food is absorbed. This is restricting the amount of food that can go into the stomach, bypassing the stomach and going right to where the food can be absorbed. Depending on where you bring the bypass to the duodenum, you can determine how much will be absorbed. So there's restriction and to some degree absorption. The next one is a combination of both. You allow some stomach to be used. What you're essentially doing is removing some of the stomach, keeping a sleeve of the stomach so that you're allowing some of the stomach still to be involved, but primarily the food is going directly to the duodenum. This is a sort of combination of both approaches, extreme restriction and to some degree absorption. And you might make the argument, why would you want to include some of the stomach? Because the stomach actually does do some absorption of food. It's actually very important for particular vitamins, vitamin B1 or thiamine. The more you can reserve the stomach, the safer that procedure is. The final one, euphemistically known as the duodenal switch, actually does a similar thing where it will reserve some of the stomach, and then it can attach to the duodenum where the surgeon desires. Now the duodenum, remember, that's the high real estate of where most of our foods are absorbed. It's maybe a foot long, and the more you restrict of that, the less food is absorbed. You can decide how much stomach and how much absorption, find the sweet spot, and you've got your duodenal switch. It's probably the most invasive surgery, the best of both worlds, as it were, although it also will get the best of side effects, which is what I want to talk about next. So to summarize, what bariatric surgery does in its various incarnations is to inhibit the absorption of food, for example, the gastric bypass, or obstruct the food intake solely like a lap band. Why would we do something that invites lots of side effects, consequences? Remember, this is for people who usually have a body mass index that's at least 30 or 25 with one or two medical conditions. When you're at rates like that, we've discovered you get all sorts of consequences: diabetes or metabolic syndrome, heart disease, COPD, osteoarthritis. It makes a lot of big changes. A person will lose weight. Within 5 years, a person can lose 30 to 50% of their weight. That's a lot of weight. So if a person is 400 pounds, they can go down to 200 pounds. Very motivating for the patient, makes them feel a lot better. How can you argue with that? It was considered the gold standard, invasive, but very useful. However, there are side effects. The major side effect is absorption. When you bypass, the stomach does do some absorption of essential nutrients. So you miss those. The patient has to take medications, vitamins, they have to take supplements. If they're not told how important that is, that can be a major factor for ongoing illness later. There can be post-surgical complications like adhesions, anastomoses, scarring that can be life-altering. Dumping syndrome, where if a person eats too much of a particular food or just too much food, they will actually throw it up or they will have diarrhea. They can't eat a regular meal anymore. Their food is going to have to be highly processed or minimal amounts and eating throughout the day. It can cause alcoholism and food addiction. As high as 20% of people who did not have an alcohol disorder prior to surgery developing an alcohol disorder after. Why? Why would that be? Because if the person is not able to eat foods like fruits, vegetables, proteins, because that food is too bulky or requires digestion, which the stomach is not able to contribute to anymore, what get absorbed very quickly is highly processed foods like junk foods that are high in salt, sugar, fat, which then will create food addiction. Is just the abundance of that food overtaxing our neurological dopaminergic system, which then develops eventually into food addiction. Or better still, just drink your calories in alcohol, because alcohol is essentially fermented, highly refined carbohydrates. It's the sugar, it's the grains, an easily digestible package. So it's going right to that duodenum, which is now going to favor the easily processed, easily digested and metabolized substances that come to it, which would be alcohol and sugar. One of the most heartbreaking side effects is weight regain. The person has gone to all that effort to lose the weight through surgery, which is a major financial and personal investment. I said that they can lose 30 to 50 pounds by 5 years, but what seems to happen after that is that a number of people will regain a significant portion of their weight back. There are the outliers that will regain all of the weight back and even more. Less than half of the people who have had surgery will maintain 30% weight loss. Nevertheless, its surgery was considered the gold standard of practice because it offered a fairly drastic, quick response. Within 6 months, you might significantly improve your diabetes, significantly lose a lot of weight, fast action with quite dramatic results. You had to have a body mass index that insurance would pay for. Surgery in Canada, wait lists might be 2 or 3 years long. So yes, it was an option that was considered a gold standard, but not that available. In comes medications, which have been around for a long time, not been considered that great, but they were there. First thing I want to say about medications for obesity is that even with new GLP-1s, medications that have come out in the last few years, I'm still going to make the argument that there's no silver bullet. There's no one medication that treats everything. GLP-1s, fairly new, and we're still in the honeymoon phase. I want to give you an outline of all the major categories of medications that are used for obesity today. We'll start with the amphetamines. These started in the 1950s, 1960s, Dexedrine, now upgrades, Ritalin, Vyvanse, ephedrine, tobacco. These are all basically stimulants that make a person's metabolism go higher. They're burning more and their appetite suppressed, so they don't want to eat. The classic potent example of that would be cocaine or crystal meth. People in the community will self-medicate using tobacco, cocaine, crystal meth, so that they don't eat. Ephedrine being a decongestant. If you've ever noticed when you take a decongestant at night because you're stuffy, you've got allergies, or you've got a cold, you stop sniffling, but you also can't sleep because you're really wired. It's actually a form of an amphetamine. Stimulants act as an appetite suppressant. They increase body metabolism and to some degree act as an impulse control mechanism. Vyvanse is used for attention deficit disorder to control impulse. In binge eating disorder, BED, I actually think that Vyvanse works more as an appetite suppressant than as an impulse control medication. Yeah, the person can lose 5 to 10% of their weight. That's not bad, but it's at a cost. The person's metabolism is higher, they're anxious, they're speedy, they're pacey, they can't sleep. If you take it for a long period of time, you can actually become paranoid. Witness when you're on a cocaine or crystal meth. Paranoia is typical. If you're taking medications for weight loss, You're not going to get to that level, but you are going to get some level of a heightened paranoia, increased heart rate. These are not pleasant symptoms, and it's a big cost to lose 10% of your body weight. Next area are the psychotropics, or the antipsychotics, or the antidepressants. And SSRIs, like the classic one, Prozac's actually used for binge eating disorder as well, or more recent Celexa. The idea there is that the person is eating from an emotional basis. So if you treat the emotion, then they may not need the food for emotional containment. That's the theory behind that. However, it's been known that some of these antidepressants actually cause weight gain and cause you to want to eat more. The have less of a weight gaining effect. They're considered more weight neutral. That was or Meridia were drugs, but they were taken off the market. They were all the rage 20 years ago, but then they found that they caused heart valve abnormalities and too many side effects, too many problems. They took them off the market. Wellbutrin, or bupropion, is another atypical antidepressant for craving management that has a weight neutral effect. Topiramate is an anticonvulsant that, for reasons that we don't know, has a weight limiting effect. Now, the success rate of these drugs are about 3 to 5%, not as much as the stimulants, but then you don't pay the same price. But you do still pay. You can get either overly sedated or overly anxious. Some people find that they can't tolerate Wellbutrin, and it causes paranoia for some people. Others can't tolerate Effexor, but then when they take drugs like Prozac, they get overly sedated. So it's not that great. You might get 5 to 10% weight loss, but you might also get weight gain. Almost across the board, you get low libido. You're just not interested in sex anymore. You might get an atypical mood reaction. In other words, a flattening effect. It might make you feel better, but some people will describe it as just feeling flat. You can get something called pulmonary hypertension and heart valve defects that can happen with, as I mentioned, the medication that was taken off the market. You have the craving blockers. They're probably the most interesting because they're trying to address the addiction component. And I think that on that level, they may be useful. They have side effects too. When there's a little bit of weight loss, is that enough to counteract the side effects? I don't think so. The weight loss success rate of these drugs is about 3 to 5% as well. Revia or naltrexone is the classic one that we use for alcohol, opiates, for food to reduce cravings. It's an endorphin blocker, and part of the pleasure of food is the euphoric high that will be instilled when you accentuate endorphins. So when you flatten the endorphin effect, you can eat the food or drink the drink, but I'm not really getting much pleasure out of it. Why would I do this if it's causing disruption like weight gain and diabetes? I just won't bother. It takes away some of the heightened pleasure that you might get from eating the food. That's the theory behind it. Rimonabant, which is an anti-cannabinoid medication, think cannabis, the munchies, an anti-munchies drug, was found to be quite effective, but it was taken off the market because the rates of suicide were high enough that the pharmaceuticals pulled that drug in the 90s. Baclofen is used for anti-craving of many drugs, primarily with cocaine. We use it with alcohol and we use it with food. Camprol and gabapentin are also anti-craving drugs that are used, but I find that with both, especially gabapentin, there's actually a weight gaining effect with that, and it's not worth the craving reduction effect. There are now some combo medications, and it's interesting because Quizmia is an appetite suppressant that uses a stimulant, fen, which was actually removed from the market, but mixing it with another drug somehow got past the FDA and it's acceptable now. They took a drug that was an appetite suppressant, added topiramate, which is an anti-craving mechanism, and then found this drug that would address both the stimulant effect and the anti-craving effect. Contrave is a drug that I see used a lot in the obesity world. Wellbutrin or bupropion is an atypical antidepressant that has a weight reducing effect, or at least weight neutral effect, and adding an anti-craving naltrexone together. You're taking the best of those two worlds into this one drug called Contrave. Again, though, weight loss success rate is less than 5%. So the stimulants started in the 1950s. The other medications have been introduced over the last 20, 30 years. Hormonal medications have been around for some time and have attracted more interest of late. There was a leptin-based medication in the 80s or 90s. We discovered that our own hormone appetite suppressant. So wouldn't it be nice if we could introduce the hormone that suppresses appetite, take it as a pill so that even if you're hungry, you take this and you feel as if you've just had a meal. It's the appetite satiation hormone. That was a great idea, but it didn't pan out because we found that a person could become leptin resistant quickly, as a person could become insulin resistant. You pour in these hormones, the body readjusts and essentially becomes resistant or tolerant to that medication. So then not only did the drug not work, but our own leptin didn't work. So that got dished fairly quickly. Metformin, the diabetic medication that helps insulin resistance and blood sugar control, was actually recognized as having some weight loss effect. Even when a person's blood sugar is normal, is used on low doses to promote weight loss. It's often used with medications like antipsychotics, which will increase your desire to eat sugary foods and will increase blood sugar. Thyroid medication, we hear all the time when somebody comes into treatment is, my thyroid, am I not being able to lose weight because my thyroid is a problem? We check the thyroid all the time. Other drugs, that's the most exciting of the newer, more complex hormonal drugs, the GLP-1s. For example, Saxenda and now Ozempic. GLP-1 stands for glucagon-like peptide 1, a hormone that we have that's released from the stomach when the stomach is filling, that suppresses glucagon, which is made by the liver to release sugar. It improves insulin and leptin resistance, and it seems to have something to do with promoting satiety. It slows down the gastric passage of food and keeps you fuller longer because your stomach isn't emptying as quickly. So it has a number of different effects. We're not exactly sure how. There appear to be some GLP-1 receptors in the brain that will reduce the pleasure-like effect of food, which contributes to the addictiveness of food. So in other words, you could make the argument that it makes foods, even addictive foods that you're eating, less addictive. So on all levels, it seems quite exciting. It has weight loss of at least 10% and not at the same price tag that you're paying for the other things, libido or can't sleep because you're so hyped up with the stimulants. It has less side effects on that level. It does have side effects, like, for example, a major side effect is the nauseousness that some people have. They don't want to eat. And that also means that they're not enjoying their food. We're in the honeymoon phase. Some people are like, good, that's okay. I'm losing the weight. I'm fine. Saxenda requires a daily injection. The more recent one, Ozempic, is a weekly injection, but it is an injection, and that can be unpleasant. There is concern about the potential for causing thyroid tumors and pancreatitis. You're fooling around with the endocrine glands that make those hormones, like thyroid and pancreas. Are they of numbers that are significant enough to have the drug pulled? At this point, not yet, but that might happen in the future. Now, Ozempic actually made for diabetics, and Wegovy is for weight loss. I don't think Wegovy is available on insurance, so I see a lot of doctors are working with Ozempic, using it as off-label for weight loss. The major issue here is, will insurance cover it? So they're trying to figure out ways that they can work with it. Ozempic seems to be a little bit better than Saxenda because you can lose as much as 15% weight loss, which is not bad. So if you're 300 pounds, that might be 30 to 50 pounds, 250 pounds, not bad. 15%, and surgery is 30%. Window is narrowing, and this is much less invasive than surgery. Mounjaro is the latest kid on the block. It promises weight loss of up to 30%. So we have that 300-pound person who now can lose 30%, a significant amount of weight loss, getting very close to surgery. I say that probably the biggest concern that I have about these medications are they're very expensive. They can be anywhere from, in Canadian dollars, $1,000 to $2,000 a month. That's very expensive. And while insurance may cover when body mass index is over 25 with conditions, or 30, once you start losing that weight, because thanks to the efficacy of this medication, you're not going to cover the insurance criteria anymore, and you're left with having to pay for it yourself. In most cases, people cannot do, and so they'll go off of the medication. And if they haven't made changes, they're going to gain that weight back. Is that successful in the end? Remember the previous medications and previous diet, you gain the weight back only to gain back more. If you're back into the same situation, plus we do not yet know the long-term consequences of these medications. I think these medications should be used with caution and as a bridge only. In the same way as surgery, if the person needs quick intervention and quick results, then this is an appropriate response. I do worry we're not learning how to use our own natural cues. Appetite satiation. Food addicts have lost their hunger cues, and taking these medications, they're not learning those hunger cues. And we're not learning is how to deal with addictive foods. If this medication flattens the addictiveness, when you don't have the protection of that medication, what happens? All that addictiveness will pop back, and now you're struggling with untreated addiction, because that is really the dynamic that has gotten you in trouble in the first place. About the surgery, I've talked about the medications, a quick nod to the behavioral treatments that the medical world will suggest, the bariatric world will suggest that you see your nutritionist or dietitian in the hospital who doesn't acknowledge the concept of food addiction. That person will teach you cognitive behavioral therapy, some kind of way to deal with emotional eating. You might learn terms like intuitive eating, mindful eating, all very good. If you're not eating addictive foods, those tools work. But if you are eating addictive foods, the addiction will just leave all these tools in the dust. Moderation of food, if you're a food addict, will not work. These are great tools that only work if the addiction is taken care of. So the surgery, the behavioral treatment, the medications are all useful, but if you don't address the addiction dynamic, they're only temporarily useful. Why are these tools not that helpful? Because one of the things we know is the food addict will eat regardless of whether they're full or not. They'll eat when they're so full and they wish they could stop. There is no desire to eat here. Is there pleasure in the eating? No, but they're still driven to eat. Dopamine doesn't care about whether you're happy right now or if it's satisfying right now. Dopamine always chasing the next. Even if the next is not going to be helpful, it's the concept of the next that is driving that person. And none of these drugs, except maybe Contrave and naltrexone, will address this. Food addicts will eat regardless of mood, happy, sad, glad, doesn't matter, they'll eat because their dopamine drive is so strong. Food addiction is chronic and progressive, and these medications may work actually at some times, but not at later times. Food addicts come in all shapes and sizes. You can be skinny, you can be obese, normal weight. All of these interventions are usually based on BMI, and food addiction is anywhere and everywhere. And finally, we need to address the food. If you're not actually looking at the food part, the addictive component, the fact that there's a food industry that's making foods that are so overpowering, that will overpower behavior, medication, and treatment, you're missing the boat. We're not looking at the real culprit in this equation, because if you treat the addictive dynamic, you may actually not need medications and surgery, and you'll find that some of those behavioral treatments will actually work. If you treat the food addiction, remove the sugar and refined starches that overpower the brain via the dopamine pathway, remove grains, dairy, artificial sweeteners, whatever triggers that engage with that dopamine pathway, that key player that will derail medications and surgery. If you remove those, interventions may work. If a person is an end-stage food addict, you'll certainly have to use the recovery tools, because addiction is a chronic, progressive, lifelong condition. Medications and surgery are short-term interventions. You need to have lifelong interventions. Basically, I want to say that if the person addresses the food addiction dynamic, stops eating the highly processed foods that make the person obese in the first place, they may find that they will lose the weight that they want, that 30 to 50% or more, maintain that way because they don't pick up the food again later. They're not going to come back in a year to the doctor's office saying, oh, geez, I gained that weight back. No, the weight is still off. They're not compelled to eat the foods that will make them regain that weight again. You may not even need the surgery or the medications, but if you need to have quick results, you can do the surgery or the medication and start to lose significant amounts in 3 to 6 months. A food addiction plan might take a year or two to lose that weight. Okay, if you don't have the time to wait a year or two, then do those interventions. But you must look at the food addiction element, because it will derail any program, any intervention that you have eventually. Food addiction stays in the background. The best thing to do is address it head on. Remove the addictive foods, remove the triggers, have a plan that will be lifelong. And then, of course, have support, because the food industry doesn't believe in this concept and, frankly, doesn't get much benefit by this, because medications and surgery pay a lot of bills for people. The food addiction world, take it back into your own hands. Eat well. Consider these options as useful, short-term interventions. Find what is best for you, and guaranteed you will find some level of success for yourself. Weight loss and weight maintenance, enjoyment of food, and general peace of mind. Freedom tastes great. And don't forget the support, because the power is ours. Thank you.